For the agent that must be in the know, Medicare Industry Insider discusses critical insight, noteworthy trends, and upcoming issues in the Medicare market.
Deciphering and debating the legislation, regulation, and what's happening in the market. I'm Jalen Jackson.
And I'm Rachel Bremeyer, and we're going to talk shop, dive deep into these complex topics, and make them understandable and actionable.
If you've ever wondered where the world of Medicare is going and how to prepare for the future, Medicare Industry Insider is the resource you've been looking for. Hey everyone, welcome to the first episode of the Medicare Industry Insider podcast. I'm Jalen Jackson. I'm the compliance officer for McNerney Management Group, and I am joined by
Rachel Bremeyer, and I'm the executive sales director at Senior Marketing Specialist. Collectively, we have over 20 years of experience in the Medicare industry, and this has been a huge passion project for the two of us.
Yeah, I've been very excited about creating Medicare Industry Insider. There's a lot of really in-depth topics in the Medicare industry and a lot of kind of constant change with regulations and legislation that gets proposed every year, and then even just general industry shifts in how people like to receive care and new models that are created. And I think what we see a lot from the agents that we work with on a day-to-day basis is a real need for someone to just kind of demystify everything that's going on.
I like that, demystify. Yeah, no, it's something that a lot of the times we'll sit down and say, these are really important topics in the industry. And then all we have time to do is say, hey, you should go read these, but not actually break down the why and why it's actually important and how it applies to them. So this is what this podcast is all about, is just making it demystified and making sure that it's applicable and timely and that you can apply it to your business and know what's going on in the industry.
Absolutely. And I think a lot of the things have kind of long and far-reaching impacts on your clients and on your day-to-day operations. And that's why we chose to start our first episode talking a little bit about skilled nursing and long-term care. This has obviously been a hot topic for a lot of years. Back when I started in the industry, it was kind of the beginning of the nosedive of traditional long-term care policies. And as we have continued on, we continue to see more and more issues in that space, both from a policy and coverage standpoint, and then more of what we'll talk about today, kind of the regulatory and market dynamics of skilled nursing.
Right. And the biggest question that we started diving into is, would you actually have access to care if you need it?
Yeah.
Which is terrifying to think about. If you look at the industry as a whole, we'll dive into a lot of different bullet points and topics in this, but as an individual, if you need care, can you get it? You're looking at some statistics, about 50% of people will need some sort of skilled nursing care, 14 more than in the last 5 years, and 80% of those people cannot afford it, which is just so crazy.
Absolutely.
It's amazing to think of that, almost everyone's going to need some sort of skilled nursing facility care. How are we going to get it?
Yeah, and I think that's one of the big questions is, how do we manage that access to care when 80% of people cannot afford to pay for it? So I think, that's an article I recently read through MarketWatch actually talked about how Medicaid is really for the middle class, because Medicaid is what is paying for that kind of custodial long-term care. But even on the shorter term front, access to skilled nursing, if you do have an injury, a fall, a surgery, something like that, is continuing to be a larger and larger issue. There's, the big kind of boogeyman talking point that we're facing right now is on May 11th, when the public health emergency ends, we will see a return to the 3 midnight rule. So traditionally in Medicare, of course, we have to have 3 midnights in an inpatient setting to qualify for that skilled nursing care. But we saw that waived during the public health emergency for the past 3 years. And unless Congress takes action, we're going to go back to that. And there's a lot of reasons that can drastically impact care.
Yeah, no, I think that's something that you bring up that's really important, because a lot of people didn't even realize that was, part of the public health emergency, and that wasn't something that they had to worry about. And they probably noticed that their clients weren't asking about that, but it's coming back. But one of the big things, basically with the 3 midnight rule, is that this was something prior to the public health emergency that they added a form that the client had to be notified. So that was something that, the government did try to like make it a little bit more readily known. But at the same time, when you're sick and you're in the hospital, do you really know what you're signing?
Absolutely.
So then you end up in a situation where you're in a situation where you're in recovery care, not actually as an inpatient.
Yeah.
And then you have to have that 3 midnight rule. So 3 midnights in a hospital for a skilled nursing facility to actually pick up that care when you need it. So it's going to be interesting to see that change.
Yeah. Well, and I think, you brought up a really good point with the advanced beneficiary notice, that form that they're required to provide if they believe a certain service or care will not be covered. But even one of the bigger issues, there was a study by the American Hospital Association that looked at from 2019 to 2021 the length of hospital stay. And they found that on average, it actually increased around 15%. And based on the way they looked at that data, they said it really didn't have a whole lot to do with COVID, but one of the largest factors in that increased length of stay was not having somewhere to discharge people to.
Right.
If they were in need of post-acute care, whether that was skilled nursing, home health, even psychiatric care had some of the longest waiting times, that was actually significantly extending the average length of stay at a hospital because there just was not a place for them to go.
Right. No, it'll be definitely an interesting situation. So you brought up that there's not actually a place to go. And one of the things that we run into a lot is just staffing too. Yeah. We run into situations where people, they post-COVID, how do you staff a hospital?
Sure.
So we're seeing that as another thing, and you'll see that over and over. We referenced several articles. One of them was from Fierce Healthcare, and it said hospitals also found it harder to place their patients during 2021, according to CarePort, with the average number of referrals per patient increasing to 32% of those referred to skilled nursing, 42% of those referred to home health care agency, and like you said, 15% referred to hospice. I mean, it's just kind of crazy that that's a large chunk of people that needed that care and not having the staff to take care of them.
Yeah. Well, and I think one of the biggest issues here is not only are people not having access to care, they definitely don't have access to care choices. What we see in that statistic, that they're having to do more and more referrals to place people in that care that they need, it tells me that we don't get to shop based on where we would like to go anymore. We get to shop based on who has a bed for us.
Yeah.
Exactly. It's based on who can actually accept us right now. And unfortunately, there's a lot of aspects of this skilled nursing care, this shorter term rehabilitative care, that are really affecting health outcomes. These shorter and shorter stays, either having harder access to even get into skilled care or having care limited once you do get into it, are really working with readmissions. That hospital readmission rate, we see every year CMS puts out data on readmission rates, and there are a ton of hospitals that are not meeting those benchmarks. Right now, we're actually looking at people who are discharged to skilled nursing facilities. Nearly 1 in 4 are readmitted within 30 days.
So sad.
And it's just that transition from hospital to skilled care is very disruptive. There's a lot of things that kind of fall through the cracks, a lot of poor communication, and it can result in worse health outcomes. But I think there are some bright spots. If we look at back to the 3 midnight rule a little bit, there's a big trend in Medicare right now to work with these accountable care organizations, kind of this newer concept. It's been around for over a decade, but some new trial programs in the accountable care system have given them the ability to waive the 3 midnight rule. And in some cases, some of those trials have actually allowed physicians to refer people for skilled nursing or home health without a hospital stay at all.
Yeah.
And it's really
a really good point that you brought up too, because that hasn't been an issue the last 3 years with the personal health emergency. So knowing that you can, with the accountable care organizations, that they can potentially waive it if you need it. So that isn't a good option for your clients, if they run into that situation. So it'll be interesting though. Another one, is figuring out networking issues. Like you said, you're getting told where to go and not getting an option to pick where and when you want to go. We're noticing sometimes hospitals or skilled nursing facilities picking and choosing what type of insurance they take and which ones they don't take. Part of that is reimbursement, but looking at the industry right now, we're looking at 50% Med Sup, 50% Medicare Advantage if you look pretty much nationwide. So that's limiting half the population to getting into where they want to go. So I mean, there's definitely that networking issue that we've run into as well.
Absolutely, yeah. Network issues, especially with MA plans. I think most people would agree skilled nursing is definitely kind of a weak spot. Now, like you said, there's a lot of reasons that skilled nursing facilities may choose to not contract with a Medicare Advantage provider, and I think a lot of it just comes down to their kind of cost of administration, not wanting to deal with prior authorizations, things like that. And of course, one of the other big aspects, and again, not necessarily helping beneficiary choice, is access to prescriptions. So the skilled nursing facilities, long-term care facilities, typically contracted with a specialized long-term care pharmacy that may only be in network for one or two plans in the market. And it really kind of pigeonholes folks into either getting on a specific plan that may not meet their medical needs the best, but maybe the only thing that pharmacy is in network for, or paying substantially higher cash prices for medications if it is an out-of-network pharmacy. So it really not only reduces that access to care, it also could potentially reduce medication adherence, increase costs. And again, if we're talking about Medicaid, people who are in a Medicaid bed at a skilled nursing facility or long-term care, increasing program level costs to, continue to stretch those budgets thinner and thinner.
Yeah. No, I mean, it's definitely going to be something in the future. Well, currently, it's not even a future thing. It's a current thing with networking issues and just being able to access where you want to go. Let's talk about artificial intelligence, because I know that's also been an interesting thing in the news. And, Big Brother's watching, and we've got all the technology. How is this affecting the skilled nursing facility industry and basically all the algorithms that go into deciding if someone needs to have skilled nursing care? I mean, that's something we're going to be dealing with in the future. So, I mean, when we're looking at everything, there was a study done, Ross and Herman was who we referenced, but they created a study basically, and what they found was that their algorithms, when they looked at who needed care and who didn't, sometimes it would lean towards the patient and sometimes it wouldn't. And then they were dealing with issues where Medicare potentially wasn't paying for it or wasn't reimbursing them for any care because the algorithm said that they didn't need it. So looking at that is going to be definitely something in the future, how, the Big Brother is watching and how artificial intelligence is going to affect our access to care.
Absolutely. And I think the big thing with artificial intelligence and these kind of predictive care models is they're only as good as the data we feed into them. And unfortunately, when you're looking at population level statistics, it does not account for individual situations. So while it can give us a good baseline of, everyone who has a hip replacement needs this much post-acute care, it does not give us a good baseline for there's still a huge difference between someone who's 65 and gets a hip replaced and someone who's 85 and gets a hip replaced. So there's a lot of kind of averaging being done with those algorithms that are maybe not allowing folks the length of stay that they need, the amount of care that they need, and maybe not looking at some of the other factors like, are they still improving? Are they able to get back more range of motion, more independence? And unfortunately, we see those folks oftentimes go home too soon, which definitely drives up those readmission rates.
Yeah, and when we're looking at this, algorithms, that is a hard word to say. They're not always, it's a technology. They're not looking at what's fair, what's right for that particular person, what's good for that person's care. They're looking at averages, like you said. So, I mean, it is something that when we were looking through all the information that CMS is proposing to take some action to address the improper use of these tools. But I mean, it's definitely on that sliding scale of like, how do you monitor that? What can they do to monitor that? So I can see it being in the news and I can see the government taking a look at it, but I think it'll be totally up in the air to see like how are they going to make this something that they can actually track and monitor and be the best for that patient's care. It's, going to be something that we'll be watching in the future. Absolutely.
And I think the big thing right now is, Medicare did issue some early proposals back in December to start regulating some of this, AI or algorithmic, predictive care modeling. But the big thing they're still doing to this day, as we see often in Medicare, is kind of benchmarking it to traditional or original Medicare, not being allowed to use any kind of internal or proprietary or some kind of external clinical criteria that's not in line with traditional Medicare, and using any data like that to actually make care determinations or coverage determinations.
Right.
So I think there's a lot of really interesting things going on. I know they've proposed creating kind of a utilization management committee to look over carrier practices on how they are managing utilization, to make sure that it's well-founded utilization management, not just cost cutting.
Yeah, 100%. It is something though too, like I feel like everyone, with the statistics that we reference, 50% of people needing care. I personally have run into that with my grandparents, just running into where they couldn't get out of the hospital because there was no access to skilled nursing facility where he lived. So he ended up in a situation where he was in the hospital as an inpatient and was begging to go home. And he lived in a smaller rural town. And it's a situation where it's not, the access to care isn't everywhere. You're going to see that in big cities. So he wasn't able to go home because there was no skilled nursing facility, and there was no home health care facilities that could even go into his home and service and take care of him. So even though he met all the benchmarks where Medicare would have picked it up, there was no option. So just thinking through all of the other options when your clients do need something like this, a skilled nursing facility, home health care, I know it's diving a little bit into a little different direction, but if they need some sort of recovery care solution,
absolutely,
do they have access?
Well, and I think you brought up a good point with, not just lack of access from the get-go in some of those more rural areas or maybe inner cities, various underserved populations, but also a time where, because of the staffing issues, because of some of the additional burdens that are being proposed or placed on facilities for like staffing ratios and things like that, is definitely driving up costs. And unfortunately, driving up those costs is also working against the financial solvency of a lot of these skilled nursing facilities and long-term care facilities. So, at one point, right before the pandemic, I know they said, as many as 70% of long-term care facilities were within a year of bankruptcy if something didn't change. And, that was probably a little clickbaity title because there's still a lot that are around, but hardly a week goes by that you don't see information about some kind of facility closing, or actual bankruptcies being filed, or financial fraud even. So it is definitely do your clients have a place to go if they need it? Can they afford to go to that place if they need it? There's a lot of things working against them.
So alternatives, because we just ran into like all the different things of between staffing issues, access to care, predictive modeling saying that they can't get care, all of that things. What do normal people have access to? I mean, we went through a list. It's not great, but one of the things that we brought up was personal health emergency systems, or PERS. It's not a solid solution, but it's a solution if you've got a person who is wanting to take care of themselves at home and you just want to make sure that they're safe. If they fall, it's going to call emergency response situation, and people are going to show up and help them, but are they going to be wearing it? Is it going to work the way you need it to work? It's one of those things that, as a caregiver, as a person who is trying to help this person stay independent, but also be at home and be safe, what options do you have? That's one of the ones that we threw out.
Yeah, I mean, it's really unfortunate because technology has enabled us to kind of keep a better eye on our aging parents as caregivers, but still be able to have our careers and, be able to live our lives. But unfortunately, it almost feels a little, derivative to, use things like Ring doorbells and cameras and, smart watches, things, it seems almost a little detrimental to basically you be using a baby monitor.
It is. It's an adult
a really
baby
fancy
monitor.
baby monitor to monitor your parents. And I don't think that's what most people want for that level of care. I think there's some folks that are maybe forced into a situation like that. But if the cost is so unreasonable, and particularly for folks who who do want to maintain some level of independence. Maybe they don't really need full-time care. I think it can be kind of a good middle ground to, keep mom or dad at home a little bit longer, let them, kind of age in place as as most people would like to.
Well, and sometimes you don't have the option to have them age in place. Just sharing another personal story. It took us 2 years to get my grandma into an unassisted living facility. 2 years. It's like daycare for adults. Like, it's hard enough. You and I both have young kids, and going through the whole daycare situation where you're on wait lists left and right, same exact thing for our seniors, especially, the baby boomers are in that age right now. So there's tons and tons of people needing that care, and there's not enough space. So we waited, she lived with my parents for 2 years while we were on a wait list. So even if you have the alternative that isn't skilled nursing facility, that isn't a home health care situation, if they're wanting to stay independent, but they can't live at home, there's just very little options right now. You're on wait list. You're spending a lot of money. I think they were spending close to $5,000 a month. It's just great. And she was unassisted living.
Absolutely.
Taking care of herself.
Here in central Missouri, that seems a little like a lot, but I know national averages, skilled nursing, long-term care, it is not at all uncommon to spend on average around $110,000 a year.
Yeah.
And sometimes that's for a dual occupancy room, not even a private room. So definitely a big issue financially for families, for people who are spending down their life savings, having to sell their home, or risking, state Medicaid agencies coming back and taking their home to recoup costs.
I've even seen situations where they spend their entire life savings on some sort of assisted living situation, then they get bumped to Medicaid and they lose the ability to stay in that same facility. So you run into that situation where then the whole family is throwing all their money at it so they can keep them where they want to be, instead of having to go to a facility that accepts Medicaid. So
absolutely,
all of those are just not great when you're thinking about aging in place.
And I think there are some, I wouldn't even say bright spots, but I think there's some resources out there. Pretty much every state should have and they may call it something different. Here in Missouri, it's the Long-Term Care Ombudsman. And it is an office that has a number of advocates for seniors, for those in skilled nursing, not just seniors, but anyone using skilled nursing or long-term care. And they're there to help answer questions, file complaints, make sure that people are getting the care that they are paying for. But I think that's a good resource for anyone who's looking at being in a caregiving situation, for anyone who's kind of looking down the road at what options are. They'll have a lot of information about kind of the state of long-term care in your local area. But there's still a lot of things as agents, as brokers, that we can do to help those clients kind of prepare for that eventuality. Again, there's a 50-50 shot. They've got just as good a chance of getting cancer as they do needing long-term care, and often those may even go together. But lots of ways they can prepare for that. Yeah.
One of them is definitely going to be looking at your client base and making sure that you've taken care of them holistically. We always joke about it kind of being like a house. Like, you wouldn't sell a person a house with all the rooms. So having a conversation with your clients about all the gaps in Medicare, all the different rooms, essentially, that they could potentially end up needing extra support and care for. So looking at home health care, hospital indemnity plan, short-term care, like you said, someone has a chance to need recovery care almost as much as cancer, if not the same statistic. So making sure that those individuals have just had a conversation about statistically what are the chances that they're going to need it, and are they prepared if they do need it.
Yeah, because we've definitely talked a lot about all the issues of accessing care, and I promise it definitely helps to be able to pay for it. If you're waiting for that Medicaid bed, or hoping that that Medicare coverage will be enough, that definitely kind of compounds your complications there.
Well, you hear the term financial devastation, where people don't get well because they're so worried about money. So if you can, as an agent, help them pay for it, they can focus on getting better and not having to worry about how am I going to pay to stay in this place the next day.
Absolutely. And I think another big action item right now for agents is on this 3 midnight rule. There is definitely the chance, and of course some talks going on in Congress and various other places, to kind of permanently repeal that 3 midnight rule, just like they rolled back telehealth, certain telehealth provisions and other things during the public health emergency that have stuck around. So I think that's a big call out too. We've got a couple weeks now where the 3 midnight rule will go back into effect on May 11th with the end of the emergency, but there is, again, that possibility that we can roll that back. I know,
Just
National
get it in front of the right people. I mean, they haven't had to think about it for 3 years.
Exactly. I know a lot of organizations, senior care advocacy organizations, National Association of Benefits and Insurance Professionals, a lot of groups are really kind of prodding Congress people and regulatory agencies to try to permanently repeal or adjust that 3 midnight rule. So that's definitely a big action item for agents and brokers, is to make your voice heard on how this is affecting your clients. If you have clients that are a little more tech savvy or able to make their voice heard, have them call their local representative. Make sure that everyone knows their thoughts on this.
And I think people think, oh, someone else is doing it, or my voice isn't that important, but I don't think that's how change happens. You have to think that your voice is important and that you have to share those stories. Sometimes having those client stories typed up or written out or have a conversation with your congressperson is a difference of them actually seeing if it's important or not. So share those stories. Those are so important. Another thing that we were discussing is collecting emergency contact information. We are talking about skilled nursing facility, which is not a super fun topic when you're thinking about aging gracefully, but as a potential caregiver, as a person who is in a situation with having to make those decisions, how nice is it if your parents' agent or grandparents' agent reaches out to you and says, here's what they have, here's how they're covered, let me walk you through this. So as an agent, collecting those emergency contact information, making sure that you have some sort of consent to work with whoever that caregiver is, whoever that person, the personal emergency person is going to be. Like, make sure you've got that information in your database.
Absolutely. I think that's so critical to, back when I was in the field as an agent, I would run what I call beneficiary appointments. So I would get together with my clients and say, who's going to take care of things if something happens, if you can't make a decision. It may be officially like a power of attorney, or it may just be, well, it's one of my kids and they'll have to deal with it. But I would always try to get everyone in the room together to say, hey, listen, I want you to know, lay all these policies out on the table. Here's what's going on. Here's the coverage you have. Here's some other things I might recommend. But the biggest thing is, if the worst happens and mom's in the hospital and can't talk, can't make her own decisions, you're going to have some calls to make. And I don't want that call to be to a complete stranger. Right. So here's my card. Here's who I am. Here's how long I've been working with your parents, your mom, your dad, whoever. And just make sure that you're familiar to them. And not only is it a great opportunity to give that peace of mind to your clients and their caregivers, it can also be a great opportunity to kind of increase that client lifetime value, because just because mom or dad can't afford that home health care policy doesn't mean the kids who are going to be on the hook for that care might not be able to afford it and think it's well worthwhile. So there's a lot of opportunity in those beneficiary appointments as well. And I think lastly, the big thing is, as you build your network, as you continue to talk to providers and professionals in your area, make sure that, even if it's not a direct marketing opportunity, get to know those hospitals, those senior living communities, those skilled nursing facilities, and learn a little bit about where do you discharge to, who do you have problems with, who do you really like to work with. Those are really invaluable things to know for your client's peace of mind, because a lot of times we sit there with a client and we may go, okay, who's your primary care doctor, what drugs are you on, things like that. The vast majority of people aren't asking, okay, if you break your hip and need to go in a skilled nursing facility, which skilled nursing facility do you want to go to? Right. That's not part of the network due diligence most people are doing. Maybe they should, but since that is a not as common occurrence, a lot of people aren't asking about that up front. So it's great to have kind of options and background information from providers in your area for that.
So if you do have any questions, feel free to reach out. And I hope you enjoyed this episode of season 1, episode 1 of our new podcast, Medicare Industry Insider.